This is our State of the Technology presentation regarding ventilation and resuscitation. Here to share his insights and expertise in this area of resuscitation technology is Dr. Sheldon Cheskes. Dr. Cheskes is a professor with the Division of Emergency Medicine at the Department of Family and Community Medicine at the University of Toronto, and he's a scientist at the Li Ka-shing Knowledge Institute at St. Michael's Hospital in Toronto. He's the medical director for the regions of Halton and Peel with the Sunnybrook Center for Pre-Hospital Medicine. He's also one of the PIs for the Canadian Resuscitation Outcomes Consortium and a recognized international authority in the area of CPR quality and out-of-hospital cardiac arrest. Dr. Cheskes has published over 100 manuscripts in high-impact journals such as the New England Journal of Medicine, CIRC, and Resuscitation that have changed resuscitation practice around the world. So welcome, Dr. Cheskes.
Hey, Nick, so nice to see you. Pleasure. Wish we could see you in person, but hey, this will have to do for now. But it's great seeing you. I love seeing you at all the conferences that we attend, and this is just another time in a different place, obviously. But hey, we're going to make this work for sure today.
Absolutely. I really appreciate you doing this with us. So let's get right into it. The leaders of EMS provider organizations have oftentimes the final responsibility on technology purchases, including the tech that's used for ventilation during resuscitation. So, with that in mind, what insights and advice would you offer for those considering their options when they're purchasing these kinds of technologies?
Yeah, so that's a great question. I think, um, most of my research in the past is, and people think of myself as sort of a CPR resuscitation defibrillation guy, but much of my research early on was related to CPAP and impacts of CPAP in pre-hospital respiratory emergencies. So that's where I sort of got my sort of feet wet with respect to ventilation and learned a lot about what things work, what things don't work, and what things you got to really think about when you're actually looking at getting a ventilator. So to me, the number one thing is really who's going to use a ventilator, right? So, in Canada, we have BLS providers, we have ALS providers, we have critical care paramedics, we have transport. What device you're going to use is often going to depend on who you're going to be using it for. So, you're not going to get a Cadillac type of ventilator for a BLS type of group because many of the options on those ventilators aren't going to be used. So who are you going to use it for, to me, is really important. Do you measure tidal volume, rate, pressure control? Those are all critical pieces. What's your power source? How portable is the ventilator to use? Because obviously in pre-hospital care, portability is really key. Oxygen concentration. How much oxygen are you going to blow? Do you know what I mean? So how many cylinders you go through using a particular ventilator is going to be really, really important in that decision process. Inspiration expiration ratio. So usually inspiration half time of expiration. So i.e. ratio 1 to 2. Is it fixed or is it not? Can you adjust the ventilator for your CPR requirements? So if I'm using a BVM going 30 to 2, versus where I'm using a advanced airway where I'm going 10 to 1 ratio. Can you adjust your ventilator to deal with all those changes with respect to CPR? Again, CPAP, BiPAP, those are the things that I really grew up with respect to ventilation. How does that work in that particular ventilator? Can you actually put that in to play? What about data capture, integration? So, so much of what we do in CPR focuses on we provide CPR, but then looking back at the data so we can improve our systems of care with respect to ventilation. You can't capture data, you can't improve things. And I think that's really, really critical. How many rescuers do you need? So oftentimes, if you're using a BVM, you need 2 rescuers to really hold it, ventilate, to do it properly with a seal. Does that change when you add a manual ventilator? How simple is it to use, right? So if you got a ventilator that's really, really complex to use, and then you got to go try to use it in a cardiac arrest scenario, that can be really, really difficult. And listen, at the end of the day, what's so important? Cost is important. Do you know what I mean? What's it going to cost me for this particular ventilator? And what's the cost benefit in my group to spending X number of dollars on a Cadillac versus Y number of dollars on something that's very, very good, but perhaps actually better for our particular system. So I don't care what anyone says, cost is going to factor into the equation. So, that's about good 10 things or so that I think are important considerations with respect to how you're actually going to choose a ventilator for your system.
So, purchasing the appropriate tools and technology is just part of the equation for getting better care delivered. But obviously, we've got to properly implement it. So, with regard to resuscitation, are there particular best practices in resuscitation associated with ventilation that these technologies need to fit into? For example, whether or not they're going to do ventilation that is synchronized somehow to the pauses and compressions, or if they're going to ignore the compressions and just ventilate asynchronously. So,
Mm,
could you speak to a little bit about those
yes.
kinds of issues?
And so I think those are some of the training things, right? So if I'm training with a ventilator, is there mechanisms by which we can get ventilation feedback? And I'll talk about that a little bit later. But training is critical. So we need to have devices where you have a training device that you can work on it in a training scenario. That's not a real life scenario that gives the provider a sense of how to use a ventilator. So again, like you said, synchronous versus asynchronous. To me, that's a 30 to 2 ventilation versus a 10 to 1 ventilation that you actually see. Can your ventilator work with that? What if the patient starts breathing? Does your ventilator stack? Or does it not stack? And that's really important because that's going to affect your tidal volume and how the ventilator is actually going to affect that particular patient. Metronomes, use of metronomes in training to actually get down your ventilation rate to make sure you're not hyperventilating. So there's all these little tricks that are important. And then once you do the training, being able to come back and actually look at what you trained on, look at the data you captured, and then feedback can improve that sort of CQI loop to improve what you did in the first place. So I know, for example, we worked with some new sort of ventilation feedback equipment, and we thought we were great. A bunch of doctors working, we know how to ventilate, we know rate, we know depth. So we get on this equipment and we're blowing like 900 cc's. We think we can do HA guidelines, right? 5 to 600 without a blink. We're like blowing 900, like no problem whatsoever. And it shows you that how sensitive some of these things are. And if you're not measuring it, you can't improve it. And I think that's the one thing about ventilation. So much of what we do in ventilation is not measured. And I think so much of what we know suggests that ventilation is a huge part of resuscitation. So I think we've always thought about compression airway ventilation, right? Compression airway breathing, the CAB. So we focus so much on, do we got a supraglottic airway in? Do we got a BVM in? Do we got an endotracheal tube in? I think that means nothing at all unless you control the V, unless we know more about the ventilation, because I think that's going to ultimately have more impact on outcomes and resuscitation anyway than what airway we have in place. So I think you're going to see research in the future really focus on that ventilation. How do we measure it? How do we improve it? Because I think it's a big piece we know very little about.
No, that makes a lot of sense. And I think you've also kind of touched on this, but obviously implementing any of this stuff can have some pitfalls. And so, what are some of the common mistakes or pitfalls that you observe EMS organizations make, and perhaps speak to some of the things they can do to avoid those pitfalls or at least minimize their impact?
Yeah. So the big ones, I think, so training to me is huge. I think sometimes we buy things, we think they sell themselves, and when we go to actually implement it, we don't get the feedback from the street paramedic. Okay. So let's say you have a device, you're looking at a number of devices. Please get your paramedics' input. They're the ones that are ultimately going to use the device, right? So I think getting that input from your field paramedics is going to make a huge impact because they'll say, hey, listen, I can't use this in the real world for A, B, C. Okay. The second thing that I think is important is getting your medical director's input. So many EMS agencies have medical directors who have lots of input in terms of knowledge in this particular area. And I think for most EMS systems, I never like to see a provider go out and buy something without getting the input from their medical director. I think the medical director is there for a reason, and one is to provide input on decisions such as this. But sometimes that's overweighed by things such as costs and other things that the provider may think is more important than the medical director's input. So I think the medical director, obviously maybe a little bit biased here, should have some input into this, because the other thing the medical director knows is the system. Right. So, how's this ventilator going to work in my system of EMS care? So, I've got fire, I've got police, I've got ambulance, I've got multiple providers actually on the scene. If I've got a ventilator that is being easy to use by one, but has no clue on another, it makes it very difficult. And we talk about that with defibrillators. It's great when you have two defibrillators from two agencies that are from the same manufacturer, when the pads are easily transversed. It's just the system of care is much, much better. And then the last thing is, like I said, medical director, training. If you overlook training, you're finished. Do you know what I mean? I think that's such a critical piece. But get those paramedics' input. If I could ever say one thing, I think the paramedics know their business, right? They know what they're going to say. So they'll be able to tell you a good piece of equipment versus something that they don't think is good. But the ease of use for them is what's important. They got to deal with so many different things in a chaotic resuscitation. They're going to want something that they can rely on, that's easy to use, and makes their life easier, and makes it hopefully the resuscitation go more simpler. So to me, those are the key points that I would look at.
Fair enough. Now, another factor that comes into all of this is research and innovation. And, you do a lot of research, you've been
Yeah,
involved in a lot of ventilations. So I'm particularly interested in what your take is on the issue of the next big thing that's just around the corner, because I know when like I'm going to upgrade my computer,
yeah.
I'm always a little paranoid that as soon as I buy X, the next thing is going to come out, and I'm going to miss out. And fear of missing out is a big thing in all dimensions of life, right?
Yeah.
So with that in mind, what sort of things from a research perspective or a product innovation perspective, are kind of out on the horizon that these EMS decision makers contemplating the purchase of these technologies should at
Yeah.
least be aware of, and maybe they pump the brakes a little bit on making a purchasing decision, or maybe it's just something they're going to keep an eye on and wait for this to come to market. So is there anything in those dimensions that you'd like to, maybe share with them?
Sure, for sure. So very, very topical questions. You know what I mean? So I think I alluded to this in my previous answer. I think ventilation measurement is going to be key in the future. And to me, we know, and certainly I'm a big believer in CPR feedback, and I think CPR feedback has made a huge impression in terms of improvement in CPR quality. Whether that's shown an improvement in outcomes and whether ILCO or AHA believe that, I strongly believe in CPR feedback because I've seen it in my own system of care. I think the next big thing is going to be ventilation feedback. Can we provide to the provider in the field not outcomes, but ventilatory rate, ventilatory tidal volume during a real life resuscitation? So there is technology out there that is looking at ventilation feedback. So you look at your screen and imagine you're seeing one portion of your screen on your defibrillator has CPR rate, CPR depth, CPR and CPR release. What about if you had on another part on your screen your ventilatory rate and your tidal volume? Okay, right at the same time as you're doing the resuscitation. To me, intuitively, that is going to improve CPR quality from a ventilatory point of view. And that's never actually been studied. So recent research suggests in a mannequin model that by using ventilation feedback, we completely improve significantly tidal volume and the rate in terms of the way we ventilate. The question is, this is a mannequin model. So I've received some funding and grant funding to look at this exact same question, but in real life EMS. So what we're going to be doing actually over the next month or two is a before and after study. And in the study, what we're going to do is we're going to give our paramedic services a device that actually measures ventilation quality, but we're not going to turn on the actual dashboard. We're going to collect data on 200 patients. Then what we're going to do is after X number of months, we're going to turn on the dashboard and see what we see before and after with respect to ventilation feedback, and if that makes a difference in terms of how performance is actually done. The big picture, though, is using this to see if we can tie ventilation parameters to outcomes from out of hospital cardiac arrest. No one has been able to do that, to see, does ventilation feedback make a difference with respect to outcomes? Can you measure ventilation, tidal volumes, and how those actually make a difference? So we know HA says 500 to 600 cc's tidal volumes gives us certain rates in which we want to ventilate. But what we know is that very few people actually have measured that and see if it actually makes a difference. What we do know is when we do 30 to 2 compressions, that very few times when people do 30 to 2, do they actually do two ventilations in that window. And if you look at the recent research, what you see is those people who do closer to 2 ventilations have superior outcomes. The trouble is most people do a half or one ventilation in that 30 to 2 window. So these are really, really important. These are things that we've never measured before. We've got some evidence to suggest hyperventilation is bad, large tidal volumes are bad, but let's measure it now and see, hey, is 500, 600 the best? If it is, we'll find it out in our research. So we're really excited about this. We think this is cutting edge. And again, we think it'll make a difference in resuscitation moving down the road.
Sure. And all that kind of suggests to me even the possibility for further iterations if we're measuring this, can this even be automated so that, we automatically are adjusting those parameters on the ventilator to match the parameters on the monitor. So I think you can see how the dominoes could potentially fall with this over the next several years. Exciting
Totally.
stuff.
Yeah, and think about it too. We're just talking about this now, ventilation feedback for cardiac arrest. What about traumatic brain injury? What about other injuries where ventilation is critical? And we don't have that right now. We go what we think is good, but we don't have that real time feedback for the paramedic to say, hey, I think I'm doing great ventilations, but hey, when I'm looking at the screen, it's actually 12 to 20 per minute as opposed to what I think I should be doing. So if I had that real time feedback, I think it really would make a big, big difference. We've seen it in CPR. I think we're going to see it even to a greater degree in ventilation.
Absolutely. So to wrap this up, I just want to give you an opportunity to mention anything else that you think buyers of ventilation devices or technologies should be aware of, or perhaps want to re-emphasize for EMS decision makers when considering their purchasing options.
Yeah. To me, don't make the decision based on cost alone. Think about who is actually going to use a ventilator. And once you figure out who's going to use a ventilator, get their feedback in. Do you know what I mean? So I just think paramedics have so much excellent input to provide to the decision makers, and we oftentimes don't ask them enough. And I think if you don't ask the paramedic, you don't ask the end user, you're going to get a device that your whole system may not actually look at and actually appreciate. So get input. Don't make it a cost alone solution. Don't always buy the Cadillac because you don't oftentimes need the Cadillac in these situations. And make sure it does what you want it to do for your particular EMS system. If you do those things, you'll make a good decision at the end of the day.
Well, great advice all the way around. Dr. Cheskes, thanks so much for taking some time to help us better understand what should we be taking into consideration when we're thinking about purchasing ventilation devices and technologies, particularly when they're used in resuscitation.